Hello, very good evening to everyone who is attending this webinar organized by the Basic Science Subcommittee of Indian Orthopedic Association. As you are aware that today we have amongst us our key speaker, Dr. Anand J. Thakur, and this program will be presided over by none other than the renowned spine surgeon and our very own Dr. Ram Chadha ji, and who doesn't really need any introduction to the orthopedic community of the country. And over to Dr. Ram Chadha sir for your words of wisdom before we start this program.
Good evening, everybody. At the outset, I welcome the speaker, our very senior Professor Dr. A.J. Thakur, and appreciate the effort that he's put in giving us knowledge and wisdom packed together over the last 4 decades. On behalf of the Indian Orthopedic Association and the Basic Science Committee, headed by Dr. Shobha Arora, with Dr. A.J. Thakur, Dr. Bhaskar Bargoin, and Dr. Samarth Mittal, I appreciate that each one of you has put in a huge effort to disseminate knowledge and educate our colleagues on something which has been lacking for over the years, which is basic sciences. Dr. Thakur has written innumerable books, and each one of us have read them in bits and pieces, and the younger generation is following them to the T. It's a pleasure today to have Dr. Thakur sharing his knowledge over the years, his experience over the years that he has gained and how he's modified regarding IFM modulation, which is interfragmentary modulation for bone formation. And it will be a pleasure listening to how his thoughts have evolved and what he has to share with us today. Thank you, Thakur sir. Thank you, Basic Science Committee. And back to you, Dr. Bhaskar.
So thank you very much for your kind words and for introducing sir. So for the youngsters who are also joining today, actually this is basically for them. So I'm extremely happy to, reintroduce Dr. Anand J. Thakur sir, who has been a pillar in the basic science research in orthopedics, particularly focusing for the postgraduate, learning process and teaching. And as you are all aware that he has written a lot of books on basic science involving fracture healing and including the technological aspects like locking plate, and also on very important how to communicate in science, the power of PowerPoint presentation. These are his, the landmark books, which I'm sure the PG students should go through to, fast forward their learning in the process of, becoming an orthopedic surgeon. So with this, I hand over this, the forum to Dr. Anand J. Thakur for his, lecture on interfragmentary fixation and what are the various facets he's going to touch today, besides we normally read in our textbook. Over to you, sir.
Thank you. Thank you, Dr. Ram and Professor Bhaskar, for a very generous introduction. Fracture treatment is now commonplace, and operative fracture treatment is more commonplace than conservative fracture treatment. For preparing this lecture, I was trying to find out an X-ray of shaft of femur treated without surgery, and I couldn't find one because almost every fracture shaft femur is now being operated. Having said that, the most important part is how to apply the instrument, how to apply the implants that we use, and that really is the crux of the matter. Orthopedic surgeons are known to modify a method before trying for the first time, and that is what causes all the trouble. Today's topic is modulating interfragmentary motion for optimum bone formation in plating. Before we go into that main subject, I will just introduce myself. Now, God, this is not moving. Okay. So as I said, this is all I can talk about myself. My first book was published 25 years ago, and it has helped a lot of doctors, particularly postgraduates, in knowing when they enter the operation theater for the first time. They get a lot of information and solace by going through this book. After that, I worked on locking plates when they were introduced in 2001. And 2015, I came out with this book, which gives considerable amount of information on locking plates. Every day we order X-rays and we find it difficult. Which precise X-ray we want is difficult to remember, also difficult to tell the technician how to take it. So this source book is very useful to most of us who use it. My passion for presentation in PowerPoint has led me to write down and put down some things which are not available on WhatsApp or on YouTube or in the regular commercial books. This really talks about the philosophy of presentation for a medical audience, and it's very useful those who read it. And this, lastly, I have modified this famous book for South Asian conditions and has recently been used quite right. Why should we study basic sciences? When we are in medical school, we study anatomy, physiology, biochemistry, pharmacology, pathology. By the time we come to orthopedics, our basic details have gone, but the framework of knowledge remains. As a background for further studies, we remember the words, we remember some details of the anatomy. And when we study orthopedics, we are able to read literature, follow what is being talked about. So it is useful. Most of the things which we treat when we practice orthopedics, we tend to overlook the basic information or scientific information and go straight on to do the plating. Same thing happens in bone plating. We all want to do a plating, but what are the fineries we tend to overlook in our day-to-day job? Starting with how the fracture heals, the natural mechanism of fracture healing is to reduce the fracture mobility at the fracture site. From the hematoma to the callus formation, you can see first there is swelling and muscle tension that reduces the movement at the fracture site. Then fibrous tissue forms, then the fibrocartilaginous tissue forms. At each stage, the movement becomes less and less. And when it becomes fibrocartilaginous and calcified tissue, then movement also almost disappears. When the calcified tissue turns into osteoid, the patient feels the relief, he is able to use the limb, and the impact of the fracture is lost on him. He feels this is over, but technically, till the complete remodeling takes place, the healing process goes on. In all this, what we are looking for as orthopedic surgeon is callus. Callus is lovable, likable, laudable. So why it is so? What it does is increases the circumference at the fracture site. When before the fracture, the circumference or diameter is so small, but after the callus forms, it suddenly becomes 3 to 4 times. With this increase in the diameter with the substance, it becomes stronger against torsional and bending forces. To understand this in technical terms, we have terms like polar and area moment of inertia. Increased circumference in technical terms means higher polar and area moment of inertia. What is it? In simpler words, if you have a round object of a smaller diameter and a larger diameter, then the larger diameter object will be stronger against the rotational forces. It is as simple as that, but we have to use technical terms, and it is called then polar moment of inertia. If we apply torsion to an area where there is a large circumferential diameter, the rotatory or torsional forces are called as polar moment of inertia. If you take a bar of 4 millimeter and of 7 millimeter, then the bar of 7 millimeter is stronger when bending forces are applied. Look at it. Here is a bar which is when you apply a bending force, the displacement is quite marked. When the callus forms, the diameter and the circumference of the fractured area increases. And now if we apply the same bending load, then the displacement is not as severe, but is hardly anything. So what it has given, the increased diameter has given the additional area moment of inertia, that means strength, to withstand bending forces. So that's what we are. This happens only because there is callus. If there was no callus, then these things will not happen. So we have these two terms, polar and area moment of inertia. Alan Apley was a very respected orthopedic teacher. He knew how to make his talk interesting. And he also knew that the moment you mention sex, all the orthopedic surgeons wake up and pay attention. So he said, callus is like sex. It's natural. It joins two things together, and it requires a bit of movement. Alan Apley was known for his sense of humor, but they requires a bit of movement is more important for us in today's talk. Fracture treatment aims at callus formation, and the callus formation depends on some movement there. In non-operative treatment, always throws abundant callus. We used to use splints for lower limb, splinted fractures through abundant calluses. Here you can see there is a malunion, but the callus is in abundance. So splinted, we just reduced the mobility to some extent, and there was tremendous amount of callus. Same thing in a plaster cast. The callus formation is quite rare. Both the instances, there is no surgery, only non-operative treatment, non-surgical treatment, and we have got a tremendous amount of callus there. When we use internal fixation, we can produce three types of mechanical ecosystems. We can have compression, we can produce an area of absolute stability, there is no movement at all, or we can have a fixation where there could be some movement, or it could be a lot of movement. Giving by example, before we go, that stability is a property of fractured area, and it describes how much movement is possible at the fracture site after fixation. In technical terms, it becomes stability is defined as a degree of displacement between the fracture fragment. In simpler English, it means after you have fixed, how much movement is possible between the two fracture faces. That is the stability. Lesser the stability, better, or it could be called as relative or absolute stability or instability. Rigidity is the property of the implant. It really means the strength of the implant. How much deforming forces an implant can tolerate. How much DHS can tolerate weight. That is its rigidity. So it is the strength of the implant which is called rigidity. So these terms, stability and rigidity, they sound similar, but they are different meanings and in different connections, but both are used in fracture treatment discussion very often. So internal fixation could produce relative stability, and that will lead to secondary healing and callus formation. And if we use our technique so well that there is absolutely no movement at the fracture site, then no outside callus will be seen, and the fracture will heal by direct scraping substitution. From one cortical end, the bone will grow into the next cortical end, and we will have excellent union. Here is the example where the fixation has produced adequate amount of callus, and this is secondary healing. Now the same implant has been used, and you cannot see an iota of callus, no callus whatsoever, because the technique used is no movement at the fracture site, and the bone healed from end to end and including across the medullary cavity. And you can produce a fixation which does not give any stability, and then you can get X-rays like this. This is absolutely badly done, poor choice of implants and poor technique, and that has produced this kind of fixation. When we do internal fixation, we want to achieve natural healing and restore the limb function in the shortest possible time without compromising any safety of the patient. So that is the real goal of the infection. The natural healing means callus formation. Now, we would choose our method depending on what fracture we are treating. If it is a multi-fragmentary fracture, then we will choose relative stability. And if it is a transverse straightforward fracture, then we had to go for absolute stability. And depending on what kind of stability we want to offer to that fracture, or that fracture demands, we had to decide how much long plate we will take. Now, there are certain situations where absolute stability is important or essential, and they are intra-articular fractures, dilated non-union, and transverse fractures. In these situations, we have to produce absolute stability. And absolute stability means once you have fixed the two bones together, there is hardly any movement, or just about 2% of the original fracture. That means very little, not even a jog, less than a jog, that kind of mobility. So no movement, such stability sends signals to the bones that everything is good. There is adequate amount of stability. Now cortex to cortex healing can start, which requires absolute stability. So this is
Sir, I'm
what.
sorry, sir. I'm sorry to interrupt. I think you have turned off your video by mistake, sir. We can't see you, sir. If you could just turn on your video.
Yeah,
Thank you, sir.
Okay. My screen was available, isn't it?
Yes, sir. Your screen is available. We could hear you, but we lost your video, sir.
All right. Sorry, my mistake.
We could see your slides, but video was not there, sir.
Okay. Slides are more important than me.
As slides are more important, sir.
All right. So there we go. So hardly any movement, 0 to 2%, and not even a jog, and we have this absolute stability. How to produce? The most common feature these days is that we have this DCP, dynamic compression plate. You put extrinsic screw, you put a screw in the offside position and compress it. This is the most common way. However, many times this is not sufficient, or in smaller bones like fibula, you can apply a Verbush clamp and then compress that as shown in this picture. When it comes to lower limb, and at many times in humerus, you must apply the articulated tensioner device to produce compression. Depending on the plate holes, to produce adequate compression is not the right policy. In femur or in tibia, whenever you have to apply compression methods, please use articulated tension device and produce substantial amount of callus, then your success will come through. So that is what the absolute stability is. There are two other ways to produce a lag screw. Lag screw through the plate is the ultimate method of producing absolute stability. It's a bit difficult procedure, but it can be mastered and it could be used when you want to go. The situations demand and you want to produce this kind of fixation. This is the right way to go. But most recommended method. This is an example. You can see the tibia is fixed with absolute stability, and there is no callus seen whatsoever there. When putting, you can also produce outside, as it is shown here. The screw is not through the bone, it is outside, and this is also a good method, producing absolute stability at the fracture site and then give a neutralization plate on the top of it. This is an example of what I just discussed today. So what are the factors that will help us in enhancing interfragmentary movements? Is the plate material, plate geometry, plate bone offset, working, etc. So we'll go take them one by one. Plate material titanium is more elastic than stainless steel. So for this reason, titanium has become more popular. However, if we reduce the thickness of the stainless steel plate, it will have the same amount of flexibility as titanium. But in technical terms, titanium is preferred. Also, it is supposed to be anti-infection. So that's why it is being used popularly, but there is no harm in using stainless steel plates with a slightly reduced thickness to get adequate flexibility. The other material is polymers. There are a few features of titanium. It has low elastic modulus, hence longer fatigue life. Titanium plate should be bent more than SS. When we want to bend it against a transverse fracture, it has to be bent more because it is elastic. Stainless steel, you have to just make a small dent. Here, you have to make it a curve to get the adequate pressure across. Titanium screws are soft to put in, but once you get the hang of it, you know what to do with this. It is corrosion resistant and it could be identified with various colors. So these are some features of titanium material as such. PEEK is the new material which is radiolucent and it can be used frequently. It can be of different strengths. So adding carbon fibers to PEEK material, one can increase the strength to match titanium's flexibility. And the advantage is that they are radiolucent, so we can always find out how it is working. They are biocompatible in bone and can be sterilized by most methods, including steam heating. They are X-ray translucent and non-magnetic. Therefore, they don't heat in MRI. You can go for MRI features, etc., etc. They are being used increasingly, more so in the humerus. I have seen them very often. Not so much in the lower limb, but where possible, PEEK material can also be used. Plate geometry thickness, as I said, thicker the plate would be less flexible. In titanium and stainless steel, usually ratio is 1 to 2. 2 millimeter titanium plate would be same flexibility as this 1 millimeter stainless steel plate. This is a rough guide, but so here we don't have much choice. The manufacturers work out a nice method and then provide us with the available plates. When it comes to placing the plate in locking plate, it is essential that it is put off the shaft. It should not touch the bone, but it should be offset by about 2 or 3 millimeters. There are small studs available which can be inserted in the locking holes so that the plate stands a little away from the periosteum. Then do your fixation and then remove those studs. So the plate stands off guard. I mean, it stands above, offset, plate offset. Unless there is plates offset, the flexibility is not optimum. This fact is often forgotten, so I'm reiterating it. Try and put those studs under the plate so that the plate stands a little away from the periosteum. Then do your fixation, and at last, then take out those studs. You will have excellent flexibility of the locking plate. Plate length is very important and it influences interfragmentary motion. As early as 1910, people had realized that immobilization doesn't fear formation, but movement does. So we want really movement. And if callus is good way of bone formation, and then it may be the best movement that deflects. I can't read this.
You have to move your camera part. That will move wherever you want to put below in the slide.
Yeah, okay, yeah, that's better. If callus is maybe a bit movement and the fracture site after fixing would be a good idea. What we do is we create an assembly that gives relative stability to the fracture site. Relative stability means we need interfragmentary motion. Then only we get relative stability. Again, to show you graphically, it is little more than the absolute stability, which was next to nothing, but now we get 2 to 10%. It's a little more than 0 to 2%. And this is the limit that is required so that callus formation is abundant in very big. Long plates are useful because they reduce stress in the plate and screw. They offer better mechanics. Length of how long a plate depends on the fracture pattern and the way you want to treat it. You want relative stability or you want absolute stability for that particular fracture, which may be transverse fracture or maybe comminuted fracture. So 2 factors. When there is a comminuted fracture, you should take a plate which is 3 times longer than the length of the fracture. For simple fracture, it should be 10 times longer. To give you an example, this is the fracture zone is about 7.7 centimeters. The plate used is 23 centimeters long. 3 times the fracture length in comminuted fractures. There we are, and it healed in record time. Treating a transverse fracture, we have used a plate which is 16 millimeter long, 16 centimeters long. So the ratio is 1 to 16, a long plate as far as the fracture zone is concerned. The long and short is that you use longer plate, as long as possible, as long as you can take, you should use it. Longer plate does the trick. In an example, this was treated and since the plate walked out, we had to remove it early at 24 weeks. And she was treated in Sarmiento brace, but it did not heal for 52 weeks. So the next step was to use a longer plate. No bone grafting, simply application of long plate that gave the adequate stability. And this was in October. By January, it showed abundant amount of callus. And by another 6 months, there was absolutely no issue. So all what it was done was giving a longer plate which offered the required stability and healing completed by itself. The mantra for mechanobiology is that longer plates but fewer screws. How does that work? You got to use minimum 2 screws. Less than 2 screws will not work in a plate. 2 screws per main fragment with purchase at least in 3 cortices. But if it is comminuted fracture, then 4 cortices are important. For simplicity, make sure that at least 2 screws per fragment with 4 cortices. Don't go for 3, it could be very dicey. Place the screws as far as possible from one another. The nearest hole from the fracture site is variable where you put that. You can put it here or depending on comminution or something, you will have to shift that. The first, you put one closest, and then the second screw, you must push the farthest. Nearest hole from the fracture and then the farthest hole from the fracture side. There we are. Now, in between, you have a choice, and that will increase the stability required. When you put the 3rd screw here, your stability against axial loading is registered. When you put the 4th screw, you have taken care of rotational forces as well. So 4 screws in one fragment on either side is more than adequate in majority of cases. Spread out screws in long plate exercise high leverage. This reduces the pull-out load on the screws. Going by the longer the screw lever arm, the greater the resistance to the pull-out. I'll just explain this on a way. These screws are put very close to each other, and we put a small load, just 10 Nm, and then see what happens. It comes down. It breaks so easily. Now, in the next experiment, we spread out the screws and now apply 10 millimeter, nothing happens. We put 20 millimeter, nothing happens. 30 millimeter, nothing much happens. So simply by spreading out the screws, we have increased the hold of the screws and the plate and reduced the destructive forces. So always spread out the screws as the condition permits you. Here, as much as 50 Nm is done, slight displacement at the farthest one, not even the closest one. So there is good reason why we should spread out the screws as much as possible. We recommend longer plates in quest of higher IFM. How to achieve optimum IFM? By altering the working length. The working length is the distance between the two closest screws on either side of the fracture, which is very well known. Now, these figures are arbitrary. 34. In the first example, there is 34 millimeter working length, and you get the relative stability of this. The interfragmentary motion is something like this. So we increase the working length to 70, and our interfragmentary motion also increases. In the third example, we will do 106, and it goes through the roof. So simple solution, isn't it? Maximize the working length to maximize this. So there is no end. We can get as much callus as we want. But there is a flip side, adverse effect. As we increase the working length, there is increased strain, which is damaging force at the screw bone interface. There is high interfacial strain, IFS, which leads to screw loosening. All these red marks are IFS, interfacial strains. And depending on where the screw is placed, the amount varies. How to reduce the strain IFS at the screw hole to prevent the screw loosening? There is a calculation. The trick is called screw spacing. The distance between the first two screws closest to the fracture on either side. Now, this is the screw spacing, and if we change the value of this or we space them further, we will get less IFS. And so, first two screws on either side, this is the screw spacing. So, instead of this screw, we move it along, then the screw spacing has been increased. We'll see some example. What we have done is eliminated two screws for optimum working length. No screws in first, but then we have taken the third one, first screw, and the next one here, and the last one. As I said, first and last is absolutely important. We have put the third screw here. And you can see what is our IFS, what is our strain level on this thing. 349, then we go to 359. You can see there is some reduction, some changes. In the third example, 369, this is the least one, or the best condition that we can give. We go further up and we find the stresses are increasing. And there are more stress on the last one, so it's more destructive. So in the four examples that we have just seen, this one, that is two spaces after the first one, as we call it 3, 6, and 9 combination is the best. You get the least destructive forces at the screw bone interface. So this is the most stable fixation method. In plating, if you leave two holes next to the fracture line, you get the optimum IFM, and then you leave two for the next one, then you get the least destructive forces over there. Optimum spacing is 369, and there we go. I just explained this thing to you, this visual presentation. So this is all complicated, out of intense complexity. Simplicity is emerged, and the simplicity is what you need to remember is this. Two blank holes on either side of the fracture will give you maximum interfragmentary motion. And two blank spaces, blank holes, will give you minimum destructive forces at the screw bone interface at IFS. So that is all you got to remember, 2 and 2 for IFM and IFS. It's just repeating for visual. This two blank holes result on maximum, two blank holes after first screw, minimum of IFS. This example, this screw just walked out. So what was done is to change it to a longer plate. I think I showed you this earlier. All that was done was a longer plate with more spacing, and it worked very well. Here the working length has been increased and the screw spacing is fairly wide, didn't cause any difference, and in 3 years there was excellent healing. Here there is a large gap, so the screw spacing was reduced, the working length was reduced by putting a screw here. So this is adequate short working length, which will sustain this fracture fixation for a long time. Screw spacing has increased, so that gives a good stability and reduced IFS levels. Now, just example, if you have a large gap and you apply a plate with a fairly big working length, then there will be a lot of strain on the plate. But if you reduce the working length in the large gap, the stress factor on the plate will be reduced. So if there is a large gap, then you should reduce the working length to appreciable level. If there is a very small gap and you apply a very short working length, then there will be a lot of stress on this fracture and it will break. But if you use a long working length, then there will be less pressure, less strain on this plate, and it will last longer till the fracture touches each other, healing takes place. It will last longer time till the healing occurs. If there is a perfect contact, then it really doesn't matter whether you have the working length of this or this. It doesn't matter. It helps because the bone is taking weight along with the plate, so it is not under any stress and it will heal without any discomfort. Plate stiffness and working length will modify interfragmentary IFF, interfragmentary motion, and hence relative stability. But in many places, this system does not work, most notably at the lower end of the femur. All calculations are correct, but it still does not work. So what do we do? The reason it doesn't work in locking plate, that locking plate only bends at the flexibility is only at the plate level. So this is all very stiff, and when we bend it will it bends more at the far cortex and less at the proximal cortex. So bone formation is more at the far cortex, less at the proximal cortex. So if the plate doesn't bend, what do? We invent a flexible screw, far cortex locking screw. When loaded, the screw bends, as you can see here, and we apply to a plate which is loaded. It will bend, it will flex, but the bending is parallel with proximal and distal cortex bend equally well. So we have uniform parallel bending because of the flexible screws. Enhanced and parallel. It's increased as well as it is parallel. Now is a laboratory specimen. You can see the lock plate, and in the near cortex there is hardly any callus formation. You can see in this kind of article. But when you use the far cortex locking screw, the flexible screw, there is abundant amount of callus formation at this side. You can see it's all blurred, but in the specimen you can see the abundant amount of callus, both at the far cortex and the bone. So there is advantage of using far cortex locking, and it is being used. It is being popular and it has been available. Initially, 2 models were available. Now this one has gone out. It has been withdrawn by the manufacturers, but the other model is working very well. There are some examples from the originator, Professor Potlak. He has given me these pictures. I can see abundant amount of callus formation here. But the far cortex locking doesn't work in very short screws. So what do? We invent another plate, which is the principle being impact damping by elastic fixation. We take a small piece of metal and then enclose it in silastic. It has got threads inside, and now this packet is introduced in the slot in the plate, and then you have a plate which looks like this, and on the side you have got this silastic sandwich going inside. One has to pass screws from here, as we have shown. It is applied in the standard fashion and works very well and produces again lot of movement. Stimulates circumferential callus formation yields faster and stronger healing than the standard locking plates. This is most important. Again, this is animal experiment. You can see the callus on both sides in far cortex as well as on the lateral cortex. So circumferential callus in locking plate is only the far cortex callus formation. So superior callus formation with the active plate we can see there. This is human X-ray sent to me by the originator again, and you can see abundant amount of callus formation there. Another method is biphasic plate. We take a very thick plate and make a slot on it. So when loaded, the plate will bend. And when not unloaded, it will open up. So there will be movement in the plate itself, but at our command, and it will be more efficient because we have made a provision for that. So slot facilitates flexibility, and this is the rigid. When it touches each other, it becomes rigid and solid. But when it is unloaded, it becomes flexible. So double advantage. This slot has been beautifully inserted in this. It is still in the experimental stage, being used on human beings, but we don't have any X-rays available for that. So before I come to question and answers, I want to summarize what we discussed today. What is the importance of callus formation? Without callus, the natural healing process does not play. To stimulate callus, we have to use the right material for the plate. We also need to use the right thickness so that the adequate amount of movement is available at the fracture site. We have to put the plate off the bone, and the plate bone offset must be observed. The length of the plate should suit the requirement, whether we want a callus formation or we want no callus formation. So plate geometry is variable. We have to rise to the occasion, and the working length and the screw spacing are to be avoided so that the plate stays in the position till such time the fracture healing takes place. And if all that doesn't work, we have newer material, newer implants like far cortex locking, active plate, and biphasic plate. With that, I can conclude the talk and I can answer a few questions if you have.
Thank you very much, sir. I think at the start, Dr. Bhaskar said that this talk for the basic sciences is going to be meant for people at the early learning stages. But I think I consider myself as a high volume trauma surgeon, and I learned so much from this talk that it is difficult for me to put it in words. Your book is absolutely amazing, and I remember when I met you at IOCON last year, I was starstruck meeting you because I'm a big fan of your book, and every time I read it, I find a lot of new things that I learn from it. Every time I have to go to a basic course to give lectures, or if I have to prepare a talk on what is a bone screw, what is a bone plate, I read your book again and again, that same chapter, and I get more and more out of it every time. And thank you so much for such an amazing talk today. I think the graphics that you use in your talks and the way you show how forces are put and what will happen, I think that makes it really interesting, not just for the young surgeons, but even for the very experienced trauma surgeons. Sir, we have a lot of questions. So coming to the first question, I think you said in your talk that between a titanium plate and a stainless steel plate, there is a increased elastic modulus for a titanium plate than a steel plate.
Yeah.
But to get the same modulus, one could decrease the thickness of a steel plate to get the same modulus of elasticity.
Yes.
But in the previous part of your talk, you said that the stiffness of a plate is the rigidity. So decreasing the thickness of the steel plate, would it not decrease the rigidity of the plate?
Yeah, I mean, depending on what load you are expecting, if you are putting it for the upper end of the femur or subtrop, then it's wise not to use thin stainless steel plate. Even if at the And actually, at the subtrochanteric level, I use a very thick stainless steel plate and not even a titanium plate. I'm afraid to use a titanium there because it is more flexible and because while a thick stainless steel, I am assured that it will last me for a long time. So, though in theory or principle, what I said is fact, but in utilization, you have to use discretion and rise to the occasion. Like in this, for nails, it is even simpler. When we use stents made of titanium and the stainless steel, the cost is a lot of matter. So we can use thinner wires of stainless steel and have the same flexibility. Same principle I used here. But as a surgeon, you will use your discretion and use the right material.
So I think it is absolutely amazing in the way that you explain that how by decreasing the cost and decreasing the thickness of a stainless steel nail like a rush pin or something, we can decrease the cost and get the same amount of elastic modulus that we would get from a thicker titanium elastic nail. Thank you, sir. The next question that I have for you is, you said that in your talk that if the diameter of the bone is bigger, then it would require greater amount of forces to break it.
Yes.
My question now is, it is a common known fact that the younger bones have a thinner medullary canal. So a shaft femur fracture in a 22-year-old man would probably take a 9 mm or a 10 mm nail. But the same fracture in a 80-year-old person would take at least a 13 or a 14 mm nail. But we all know that from experience that elderly bones break more easier than young bones, even though they are bigger in diameter. Why so, sir?
Because the quality of bone in the younger people's bone are more elastic. They are more collagen. No. The fibers are more elastic in younger people. Bone can be modulated, while that property is lost in the elderly people. It is also porotic, so it becomes brittle. That is the age difference between the younger bone and the principles which are put there mainly for the plating. Nailing is an entirely different program in which the thing is centralized. You don't have the stresses that you are to face in the on the plating part. So I usually avoid trying to compare this to that.
Sir, I will bring in Dr. Naveen at this point. Before he comes, I just want to answer, sir. Reading your book and from your experience, I think my explanation for the same thing would be same amount of bone. In elderly population, they lose a lot of bone, so there is a decrease in bone mineral density. For the same amount of bone mineral density to get more strength, it is biology and nature that increases their diameter of the bone to give it more stability, more force in much lesser amount of bone. And yes, your what you said also, that they become less elastic. Dr. Naveen wants to add something here.
Yes, sir. Yes, sir. My simple question to sir, as you shown in the slide, 2 to 10% you shown is the interfragmentary movement, or it is a strain percentage, sir?
See, that 2 to 10% is a ratio.
Of the strain or a movement?
Of the movement. Of the movement. It is original length divided by the change in the length. That is called the relative stability. So it's a ratio 2% of the original fracture length and the change, or 10%.
So that is the interfragmentary movement.
Not strain. Strains would be in neutron in N units. Newton units.
Yes,
strains would be in units. This is movement.
No. Yes. So the practical part, the difficult part for the surgeon after the fixation, he is not able to understand whether I am in the range of 2 to 10% or I am 12% or 13%.
Nobody can make that.
Most practical problem with the surgeon, and we coin it as an invisible instability even after the fixation, which is dynamic in nature.
That's why people with gray hair get better results than the one with black hair. How to achieve that stability is all that we are striving to learn, and we are still learning. So one has to, it is a practical knowledge. And,
so is there any trick to know that whether I'm in the 2 to 10% or any maneuver of rotational stability to check on table whether there is a jog of movement is happening, how much movement is happening, because it is all subjective. There is nothing objective like a smart implant where the implant can say that I am at this much movement or I am at this moment, because the next future should be a smart implant where the implant itself says that I am at 12, I'm not at 2 to 10.
Yeah,
I
next.
think Dr. Naveen, I think Dr. Naveen has asked a big question on which a lot of research is going on. And I was lucky to visit the AO Research Institute last year, and they've made a fracture monitor, which is in its very advanced stages. They've done a lot of research with the biphasic plate using the fracture monitor. And this is a monitor which can be put onto a plate. It has a battery life of around 2 to 5 months. It is still not in commercial phase. They have tested it a lot, and that fracture monitor can interact with your phone and tell you how much movements are happening at the fracture. And it should be available in the market really soon. It is the latest innovation coming up.
Just like a black box. Just like a black box.
Yeah.
Yes, sir.
Just like a
Sir,
black box.
Yeah. So my next question to you is, you said in your presentation that each fragment requires at least 2 screws.
Yes.
But since we have even audience from all age groups and very young audience as well, they might think that even an anti-glide or anti-glide plate may require screws on the other fragment. Is that a problem? Does an anti-glide plate require screws on the opposite fragment, sir?
If properly applied, no, it doesn't require. But if one puts an additional screw on the other side, it's not going to harm. Once the position of the anti-glide plate is correct and is stopping the gliding, putting additional screw in the distal fragment is not going to upset the fixation. But as an artistic thing or as a flair, one would like to do without that. I remember once somebody got very excited. Why you not put the other screw? I said, just wait and see what happens because of the anti-glide. So it's not bad to put it, but it's not required.
Naveen sir has a point there to make.
Yes, sir. The practical experience, what I say is, in a comminuted fracture, once we put the nail as a relative stability with the 2 interlocking screws on both the side in a comminuted fracture, then we feel that I think there is no enough stability for that particular fracture, and that may go for more than 2 to 10% of interfragment movements. So we add a MIPO plate, additional MIPO plate on the nail. So we are combining 2 relative stability principles, and we call it is not an absolute fixation, not a relative stability, it's an absolute stability. What is your take on that? That is the new stability pattern. And it works. It works very well.
I'll take you back to 1968, 69, 70. We didn't have locking nails that time. We had Kunchal nails. And we used to pass Kunchal nail and then decide it was not all that fixing. We used to put a small plate. And our fractures, though it was all open, they healed very well. Not much trouble that time. So now we are saying that most of the time, the nailers hyperextend the indications for nailing. They feel shy or not confident to use a plate. On the chat groups, I see several instances where a plate had done a wonderful job, but my friends are putting screws and play wires and this and that and trying to just do nailing. Don't get sucked up in one particular method. It is bad. No, both the methods, all the methods, including the method put forward by Dr. Jethwa, who is now wanting to be on the screen. That's a remarkable skill that he has, but he has acquired. He has tremendous mechanical knowledge and artistic skills. I can't do what he can. So it is different. So what you are saying, that nailing and plating as a desperate measure, yes. But the present trend is to promote it as a standard method is absurd. If you can't get adequate stability because of the 2 screws, use the locking method for the screws. In tibia, you have a new nail which will allow
multiplane.
Multiplane locking. Then you have this Oxytel nail, which is available at this moment only in America. It's an Irish product available in America. That it can be used. It promotes dynamic movement, the diffraction side. So you have to check your indications for fracture nailing and
Right.
modify them rather than
So the
promoting this
flexibility-
new haphazard method.
Yes, you are right, sir. But the flexibility and the stability both is required. And Gujarat people are very innovative in getting flexibility with the stability.
I think we had a lot of discussion regarding this in the last on the first session that we had 2 weeks back. And Thakur sir, you will have a hard time here because I know Dr. Naveen Thakkar, Dr. Jawahar Jethwa are big time nailers, and me too. I'm a
No, we are not nailers. We are the orthopedic surgeons and doing biomechanical principles perfectly. But what
I have-
observations we have come to know that there are certain biomechanical principles which are difficult to adapt practically. It is theoretical, it is okay, 10 to 12%, but we do not know on table. That's why we have coined that it is an invisible instability, which we cannot see on table, because the stability is a dynamic thing. It is not a static thing. That is the problem.
That's why you have
And
to
there is
know
a
the
cyclic, and there is a cyclic load, and cyclic load leads to some instability later on.
that is why you have to know the principles, what will create that kind of stability and practice it. The issue
I have two more questions for you, sir. Two more
Yeah.
questions. We are running out of time. Sir, you said in one of your slides that bone takes the weight, and that's why plates don't fail if the full fracture comes in complete contact and the bone gives the stability. It is a general dictum that we are taught because this session is meant for people of all ages. It is a general dictum that we are taught that plates are weight bearing and nails are weight sharing.
Yes.
If the fracture is in full contact, do the plates act like nails and do they start sharing weight with the bone?
Yes,
Do they
if
change
there is
their
a
property?
if there is a good contact with the opposite cortex, the bone will share some bone, will also carry load, and the plate will also carry load. They will share it. They will definitely share it if there is a contact. If there is no contact, then there should be a flexible fixation, and soon the callus will form. Moment the callus forms, the load sharing starts, and the stresses on the plate gradually reduce. So it doesn't happen overnight, but then slowly over period, as the callus forms, the stresses on the plate will reduce slowly and gradually. That does
And
happen.
my
But
last
Samarth,
question
the
to you, sir.
problem. But the Samarth, this problem is when there is a bone-to-bone contact, there is no problem. When there is no bone-to-bone contact and instability, then the principles of instability and how to make that stable comes. When there is a
Dr.
bone-to-bone
Jawahar,
Dr.
yeah,
both
Dr.
the
Jawahar,
implants
the
will
point.
work.
Ask the
Dr.
daily
Jawahar,
I
Jawahar,
just
please.
I just tell you on the same principle, we have come out with a point supporting plate. And you go through the YouTube and you will be knowing that what is this point supporting plate is an absolutely new concept, not even checked by AO or anybody. So that is what you say, that when it is a point supporting reduction, plate works like a nail because it is a point supporting reduction. So you go through that, and one or more, 2 or 3 things only I want to just, because I was listening on YouTube. Number one is that it is not like titanium is for MRI. All implants are for MRI. There is nothing like titanium has anything special. All are non-magnetic, so it can be done. And secondly, this interfragmentary fracture will work or will vibrate only if you do not pass interfragmentary screw. So any case, if you have passed interfragmentary screw, all your principle will not work. So what is required is that probably for the reduction, you may put interfragmentary, then you put a long with a good working length. But at the end of the operation, you remove that interfragmentary screw. Then only movement will occur. So that much. And secondly, that whole world is still waiting for the mechanical effect of bunch of nail. Bunch of nails which we are doing, multiple flexible ender nails and other nails, is basically nobody knows what happens with a bunch of nails, and that is how we are getting. But it is very interesting. All these points which you have given is very interesting. Very good.
Thank you, Dr. Jawahar. I think that is something for
Sir,
an
I want
advanced,
to add one thing.
advanced.
I want to add one thing.
Naveen sir, we
Only
are
one
sticking to basics only, sir.
Sir,
This is going
sir,
very advanced.
sir has shown that slotted plate for the distal femur. But in that slotted plate, what is added is the thickness of the plate in the distal part is different, and the thickness of the plate
Yeah.
is reducing as you go proximally.
Yes,
So
it's
that's
biphase.
both the principal slot and the thickness of the plate is variable in that principle.
Biphasing plate is where.
On this principle, we already have a prototype ready now. As you said,
Very
cut
good.
in the plate and that will become flexible. We have all now physical experiments on that, and soon we'll be coming on that. Yes.
Sir,
So,
last question.
Better
Last
days
question
for
is,
fixing.
you explained about far cortical locking screws,
Yes.
and I thought I understood it till date, but then I heard you today. Are they really elastic, sir? Because the way I understood it is that they only have hold in the distal cortex. They are locked onto the plate, but they don't hold on to the bone in the near cortex. And that is why they give movement at the near cortex without being elastic. So the substance is the same, but it's the shape of it is like a partially threaded screw, which is
No,
not
no, no.
holding on to the proximal cortex,
Yeah.
near cortex.
No. It is a sleeve. It is a sleeve. It is a sleeve. That's why it moves in the sleeve.
Now, that is the other one which has been withdrawn by AO that had the sleeve. The far cortex locking screw flexes. It's a flexible screw, and depiction is from the real time, not me, but from drawings. So it does bend. You are absolutely correct that it has got locked in the plate and the far cortex, nothing in the proximal cortex. Because it can then move, but when loaded, it will bend. It will slightly flex or bend, and that's how the parallel thing takes place. I
Okay,
will
thank you so much,
search a reference and send it to you.
because
So,
I
sir,
have used a
sir,
lot of these
sir,
plates. They are no longer
Sir,
available in India.
sir, only one
important thing
question. In that screw, you have to be exactly parallel screws. If your degree of the screw becomes it's not parallel, then that principle of flexibility
that is
and same
also
parallelity will go.
Yeah, and you have to use them. You can't mix them with other screws.
Right.
In one segment, you have to use all flexible. The other could be non-flexible, but one it should be flexible.
no,
So
no, sir.
in
When I attended their workshop, it is not the case. The near cortex is made a larger hole so that screw can move inside with the near cortex. That is the principle. Now, if
So
you
that's
are
what I
unable
discussed
to
with
pass,
Thakur, sir.
if unable
That's
we
the
are
same thing.
unable to
Yeah.
we are unable to pass parallel screw, then also it was because as in Elizaro, rotational micro movement also gives callus formation, not only axial. So that is how they are getting good results.
Sir, actually, they are passed only with the sleeve. So whether parallel or not, it has to be perpendicular to the plate because it has to lock onto the plate.
It is to some extent, but then rotational is not very well. They explain that when there is some rotation also can occur between the two fragments because of the round space. So it's okay, but
Agreed,
it is
sir.
something like, but it
Agreed,
has
sir.
been discarded now.
Thakur, sir, about the screw spacing, I that is again something that I really loved about your talk. You gave an example of putting the screw third, seventh, and ninth.
3, 6,
I
and
just
9.
want to
No,
ask-
no, 3, 6, and 9. 3, 6, and
3,
9.
6, and 9.
3, 6,
So
and
I
9
want to
both
ask,
sides.
I want to ask you about a situation that we most of us do in our real life. 3, 5, 7, and 9. We try to keep one hole empty and fill the next hole. If you between 3, 6, and 9, 3 screws, and 3, 5, 7, and 9, what would be better, sir?
We said now if there are 3 and 5, there is only one hole. The deforming forces are more. The IFS, the interfascicular strain, is higher with 3, 5, and 9 rather than 3, 6 is the right one. 3, 6, and 9 is the right one.
Perfect.
But sir, with
I
the
think
slotted plate, with the slotted plate, they have not given any holes. They have given holes in the last part only. So that does not make any mix of this screw or these hole or these hole. That's why they have refused.
Yeah,
They have taken away the confusion and they have put the only holes in
in
the
locking plate,
proximal
what
part.
is important that it should be offset. Most of the time, we put the plate on the bone and then fix it. We should use those studs to lift the plate above the bone and then do the locking business.
Yes.
Offset
I
is
think-
important.
So there is a
Thank you, sir.
distance between the plate and bone is also a very good factor for the stability and instability and interfragmentary movement.
Not very good. It is essential part.
Yes.
It will only work. The flexibility will come only if it is offset. Now,
Yes.
this
The
fact, we fail to impress this fact on the young surgeons, and that's why we don't get the desired results out
So-
of a locking plate.
So there should
Thank
not
you,
be
Thakur, sir.
chip plate. There shouldn't be any chip plate. No chipko.
No,
No,
that is
Chifu.
what is very important, that whether you are passing a cortical compression screw or you are passing a locking screw. If it's a compression screw, then it will behave differently. If it's a locking
Yeah.
screw, the space it will behave differently.
Yeah, but
Right now, I see Dr. Jawahar Jetwa and the elasticity that his seat belt has. I think that is what we need to learn, how much elasticity we need and how much stability we need. Dr. Thakur has summed up really well. Before we close, we are already beyond time. I just want to request Dr. Bhaskar to give his final words. And then Dr. Naveen
Thank you
Thakur.
so much. It was really, enlightening talk from sir. So, and one thing that comes to my mind as we close down is, as we traditionally say, locking plate is an internal external fixator. And if you see the history of external fixator, it was called a machine for non-union. But if we intelligently use this one, that becomes a machine that can treat non-union. Now, as sir has said, once we space out the screws, the locking screws in an intelligent manner, 369, as he pointed out, one of the best to construct biomechanically, which may not be possible sometime clinically because of the neurovascular status and the length of bone and other things. But once we space out the screws and use the locking principle, still it works like a dynamized internal external fixator. This is what comes to my mind as well as going through all the discussion amongst you. And I'm sure, there's a concept of isoelasticity. Once we go closer to the Young's modulus of the bone and the implant that is there, which is also, going closer to the Young's modulus of bone, often we know the huge discrepancy leads to, stress shielding and stress concentration. So I think this is one of the, in recent time, probably one of the best lectures I have attended and best brainstorming among the top, the surgeons who are, always, I call all of you a very much thinking surgeon. That is what is all about basic science. Thank you everyone for your, very lively, interaction, and thanks Anand sir, and particularly Samad for taking the initiative, to come back with the second, this basic science webinar. And thanks everyone, Dr. Thakur, Dr. Jawahar Jetwa, everyone, and all the delegates who are joining through whom we cannot see directly. And thank you very much.
Naveen sir, final words, please, sir, before we close.
Yes. We are very much thankful to Thakur sir that he has cleared many principles and given up a simple solution to complex things in a simple words. And we are thankful to all the faculty and the Basic Science Committee for such a beautiful program. Fantastic program. And we should continue this. This is very much required for the young surgeons. And we thank all the delegates for attending this and contributing and learning together. Thank you. Thank you all.
Thank you.
Thank you. We can leave the group now.
Thank you, sir.
Thank you.
Sir.
Good night.